This is Aging Forward, a podcast from Mayo Clinic about geriatric medicine and the science of healthy aging. Each episode, we explore new ways to take care of ourselves, our loved ones, and our community so we can all live longer, fuller lives. I'm Dr. Christina Chen, a geriatrician and internist at Mayo Clinic in Rochester, Minnesota. In this episode, we are talking about care transitions. And our guest today is Dr. Maria Mendoza de la Garza, a geriatrician at Mayo Clinic in Rochester who has a practice in long-term care and homebound care settings. She's a very talented clinical educator who teaches learners from all levels, including medical students, residents, and fellows. She is the Associate Program Director of the Geriatrics Fellowship Program and a wonderful mentor to many. So really grateful to have you here with us, Dr. Mendoza. Thanks for joining.
Thank you so much for having me, Christy. It's my honor to be here.
You are our care transitions expert. And so I think this is a conversation that people don't really have much with their usual providers at the primary care clinic. It's not something that we routinely hear about. So let's just start with the basics. What are care transitions and why is it so important in the context of healthy aging?
So a care transition is something as simple as moving a patient or a person across different healthcare settings. So you can think about this as a person who is in the hospital and is being dismissed going back home. That's a transition in care, or going from the hospital to a rehabilitation center, or maybe going from the hospital to the nursing home. And those are the most common transitions in care that we see. But really, a transition in care is anytime a patient is being taken care of by a team, and then that changes to a different team. So you can think about a transition in care when someone moves to a different city and has a different primary care provider, or when they go to the emergency department and from the emergency department are moved to the medical floor or the surgical floor. So that's a different team taking care of them. So every time someone has a different team taking care of them, or when they leave a different healthcare setting, that's a transition of care.
And it seems hard because change is never easy for anyone. Like any sort of change in a daily routine, I struggle with. I can't imagine just changing teams and places and care plans all the time. So what are the common reasons why older adults seem to experience these frequent care transitions?
With the older adult population, they tend to accumulate more medical conditions and more medications that puts them at risk for being more vulnerable and having more transitions of care. So they may have an infection that requires them to go to the hospital, or they may have an exacerbation of one of the medical conditions that takes them to the emergency department, or they had to be seen by different specialists that prescribe different medications.
And earlier you mentioned, going from home to hospital to rehab to hospital again. Why is this transition so challenging for older adults?
If we think about this, is kind of having different cooks in the kitchen at the same time. So I feel one of the most common is the lack of communication or poor communication between providers in different care settings.
Yeah.
When we change medications in the hospital, we start or reduce dose of medications and they go to a different healthcare setting, such as a rehabilitation center or the nursing home. That information may be lost during the transition of care. Sometimes the dismissal summaries from the hospital may not be the most reliable source of information for some of the other providers. And it's just the changing environments that makes it harder for older adults. The most common thing is the lack of communication or clear communication about what happened during this transition of care.
So let's backstep and just break down a little bit the different roles of each setting. So home is the most comfortable place we want to stay in. That's our most, safe space. Hospital is obviously when you need acute care to address a health issue. How about everything in between? What's the difference between a nursing home and a rehab and long-term care? Like, what are the roles of each setting?
Yeah, those can get really confusing for everyone. So a skilled nursing facility usually is a place that will have two different types of patients or populations. So one group will be those receiving post-acute care, and that may include rehabilitation services with physical therapy and occupational therapy. That group may include also patients receiving special wound care or special nutrition or a different type of medical care after being in the hospital for an acute situation or a surgical procedure. The skilled nursing facility will also be the place where you'll find patients that are receiving long-term care services or known by everyone else like the nursing home. And those are the patients who have a lot of needs in terms of mobility or cognition and a lot of medical conditions that require close monitoring by a nurse and provider. There are other places such as a memory care unit or an assisted living facility. Those are settings where patients may receive some help with activities of daily living and varies a lot depending on the facility and the setting.
So as care needs change, the settings change along with the person's current needs. And what are the other possible negative consequences of a care transitional experience, whether you're moving from the home to the hospital or vice versa?
So both settings can be scary and can maybe put you at a higher risk to have a fall, especially if you're having some pain or you had a surgical procedure or you don't know your way around and you're having difficulties with maybe dizziness or not seeing well. A lot of patients struggle also with not sleeping well. Maybe in a rehab facility where it's not your own bed, it's not your own food. So they may be struggling with uncertainty and maybe some depressed mood or feeling. If they were in the hospital for a long time and a lot of medications were changed, some patients that may have already some cognitive impairment can struggle with being more confused and not remembering fully whether they are in the hospital or at home or in the facility. And so the confusion can be worse when they move to different settings.
Yeah. And that's just talking about the normal consequence of a good transitional care, but sometimes people don't always get the best transitional care. What is the worst case scenario when that care quality isn't always up to par?
So the worst case scenario during a transition of care is that you really need to go back, right? That something wasn't right at the time of your dismissal during that transition that makes one of your medical conditions get you in trouble again. And the most common ones are probably the medications, right? Probably one of the most common ones is a medication error or a medication adverse event. So missing one of the important doses of medications or receiving or taking the wrong dose or the wrong medication, having an infection or an exacerbation that takes you back to the hospital.
Yeah. How do communication gaps contribute to issues during these transitions?
Well, to begin with, we are all busy, right? The hospital teams are always taking care of a lot of patients that are really sick and ill. And from the other side, working on the skilled nursing facilities in the rehabilitation center and the nursing homes, we are all trying to understand what happened in the hospital. So the communication gap is that we try to communicate between each other just by phone and using multiple things, but honestly, it is lost in translation, right? And what is not communicated to the maybe staff at the facilities. Also, every single of those facilities will use a different medical record compared to what we use in the hospital or in the clinic. So what they are documenting and seeing and entering vital signs, we don't see that. And same for us, we can write notes and orders, but they don't see that. So that's one of the barriers we can see on the communication gap. And also, maybe there have been so many specialists or teams involved during a patient hospitalization, and it's hard to tell who was driving the care or what was the decision or the conversation between them if it's not documented in a way in the system. So again, the caregivers are really essential to say this was discussed between different specialists or give us some of the information that maybe was not documented in a way.
Yeah, I'm just imagining this Swiss cheese model where if there's enough holes all lined up in the same place, eventually something's going to get missed and become problematic. And the care partners and the support system is what sort of bridges that gap and fills those holes as much as possible. Let's talk a little bit about the at-risk populations. You mentioned earlier that the more health conditions someone has, the more medications, they become more at risk. What are those certain conditions that you've seen or demographics that are associated with the most high risk of having to move back and forth from these different care transition situations?
So everyone will be at risk, right? The population that will have the highest risk will be those with multiple medical conditions. And kind of makes sense. The more medical problems you have, the higher the chances that one of those problems will get you into trouble. If we think about which specific problems, maybe congestive heart failure or chronic kidney disease, or they have diabetes or a certain degree of cognitive impairment, such as dementia. So that is a population that has a high risk for a transition of care or a readmission. And if we think from the social aspect of which group will have the higher risk, are those with really minimal or no social support. So those who are maybe not having family members or loved ones around them to advocate and serve as an extra pair of ears and eyes and an extra brain to write down questions and notes. Those who have maybe some limited health literacy levels, so understanding all the different details on the medical conditions can be challenging. Those who may have limited financial resources, that puts an extra effort for them to get to follow-up appointments after being in the hospital, challenging with transportation or affording medications. If we think a little bit further, what else will put you at risk for a readmission? The longer you spend time in the hospital, the higher the chances that you may be at risk for going back in the hospital. Or if you require intensive care unit level of care, so you were really sick, that puts you at risk for needing to go back to the hospital again.
So it looks like you're assessing multiple things all at once, looking for those clues of perhaps someone who has a lot of health issues. They may be living by themselves with very limited support. Perhaps they've been back and forth to the hospital a lot. And that might give you a clue that this person is going to be very high risk of a lot of movement from one place to another. So what are the ways that you assess for that? How do you look at someone's situation, just see someone who is high risk and would benefit from extra support during care transitions the most?
Every time we meet with a patient after being in the hospital or after they move to a different healthcare setting, we pay close attention to different things. One of them, and most importantly, is the medications, right? So whenever we change settings, the information can get lost. So a really comprehensive medication reconciliation is really important. You have many cooks in the kitchen taking care of that list of medications, meaning the staff at the nursing home and the providers and the pharmacists from the facility. So it's our job to really double check, triple check to make sure the patient is receiving the right medications during that transition of care.
And when you're double checking, triple checking, what are you looking for?
One way is to obviously look at how long is the list of medications, and that tells you also how many medical problems they may have. You also look at their chart and see how many times they have been in the hospital and whether they have multiple emergency department visits, and honestly, just talking to them. And if you have a chance to even meet with their loved ones to understand how things were working for them before they went to the hospital and whatever setting they were living, I think that really gives you a lot of information about the potential things that can go wrong during a transition of care.
So thank you for mentioning family members because they play such a critical role in all this. And like you mentioned, social support is so paramount. How do you see family members and support networks playing a role in all this? And what actions can they take to make the most impact in the middle of care transitions?
I mean, they're the most important thing during a transition of care, right? The patient may be having some troubles with pain or not sleeping well, or maybe some side effects from medications, or unable to really get all the information that the providers are sharing with them. So the caregiver is key during that transition of care by writing down questions, recommendations, changes on medications, understanding what's the situation and serving as the extra support during that transition from the medical standpoint of view, but also emotionally. As you said, it's really scary to not know what to expect during a transition of care. Even if you go back home, your usual and well-known environment, it's challenging to think about how am I going to manage these new medications, or maybe this new medication that is injectable, or this wound care. And that can be really scary. And so that caregiver can also provide that emotional support. And if you think about someone going to a nursing home for rehabilitation, it's also very scary. Like, how am I going to manage all of this and cost, and how long I'm going to be here? And so the caregiver is really key during any transition of care.
I agree wholeheartedly. I read somewhere that 80% of us are going to be a caregiver at some capacity in our lifetime, either caring for a loved one with dementia or knowing someone with chronic disease. I mean, we're all going to be involved. And I can imagine that when older adults are moved from one place to another, they just know I have to go to the hospital, or I have to go to the nursing home, or else I won't get better. How do we honor people's preferences during that time where they don't have much choice but to have to move around?
Oh, that's hard, right? I think it's so important from the provider's perspective to really engage and take the time to get to know the patient, get to know what are their preferences, working on completing a goals of care conversation about their fears, their worries, their hopes for the future, and really documenting to the best of our ability to understand what's happening. From the patient's perspective and the caregivers and the care partners and loved ones is to really advocate for completing a good goals of care conversation, completing advanced directives, and selecting that person that will be the patient's alternative voice, right? If they're unable to really communicate for whatever reason because they're not feeling well, to having that person that can say, this is what mom will want to do, or this is what dad will say if they were able to talk to us. And keeping the patient at the center, right? You say they don't have much say about where to go or what to do, but honestly, they should be the ones always leading the care. So always try to think about what the patient will have said if they're unable to communicate with us. Asking ourselves what the patient will have said about this transition of care, or whether the patient will want to go back to the hospital, or will the patient like to move to a different living environment. But if they're able to share their preference, I will say always asking them and spending the time to really get to know them and what's important to them. That would be the best way to honor their wishes.
Yeah. Having those early conversations are so important when the person is of sound mind and can articulate their preferences. And also, I think it takes a lot of stress off the caregivers who might have to make difficult choices later on, knowing that this is what their family member would have wanted. How do you initiate some of these conversations?
I usually ask, what are their worries? What are they worried about going back to the hospital? What are their worries about considering moving to a different legal environment, such as the nursing home or the assisted living facility? I asked them about fears and hopes. I asked about social support, that person that will really help them during those transitions or help them avoid those transitions. But I think when they're having fears, it's a great opportunity to pause and ask questions and see what are their goals and hopes so we can honor their wishes.
Understanding their values.
Yeah.
And having that as the driver of the conversation, because the fear of the transition could be, I don't want to be somewhere new, or the worry of I might feel pain again. And then taking those elements of what they're describing to you to bring hope back into that conversation of we can try to avoid that by doing these and these and these steps. So whatever was going wrong before, we can try to make it right.
And sometimes there are things such as who's going to take care of my dog or my cat?
Yeah.
And who's going to feed my bird? And it's something that we can help. We can work with social workers and community organizations to help that patient solve that problem that is very important for them and for their care and is putting stress on them.
A lot of patients tell me very directly and very clearly, I do not ever want to go to a nursing home.
If
I go to the hospital, please do not have me end up in a nursing home, because I think they have this perception of a nursing home as just an awful place to be where they're just going to wither away and pass away. And so having that understanding of, okay, we don't want to end up in the setting. How do we prevent you from getting to that point? I think drives a lot of thought about what they can be doing differently and caring for those dangerous points where coming out of the hospital, the first couple of days are the most dangerous, right? So my next question for you is what should caregivers watch out for or do more intently or more purposefully in the first few days after coming out of the hospital?
I will go back a little bit and think about if the patient is in the hospital and they're ready to leave and go to their next living environment, what are the things that I should be watching for? It's so different for someone who may have had a surgical procedure, so they may need to monitor for pain or extra bleeding, or if they were there for problems with their heart, maybe they should monitor for breathing and racing of their heart. So I think it's asking during the time in the hospital, what are the signs of symptoms that I will really need to pay close attention? And again, going back to the medication. So ask and double check the medication list when you go back home. And even if all of that fails and you get home and it's complicated and confusing, just call back to your primary care provider or the team in the hospital and ask questions. So I think it's very patient dependent on that situation, but asking questions before leaving the hospital is a good key.
Mm-hmm. But a common theme that I'm hearing is medications.
Oh, yeah.
Polypharmacy, that's never a good thing. And if there's any new things on board, or especially high-risk things like opioids or new medicines that can affect their brain health, that's something to really keep an eye on. Can you give us an example of a scenario where you were involved in a care coordination plan that you felt was really successful?
I hope all of them were success stories. So I can tell you of a patient that I've been taking care of recently, and the patient was living at home independently with some support of one of their adult children. The patient got into trouble because had a stroke and needed to go to the hospital. And during the hospitalization, the patient had some troubles with a new wound that required very intensive wound care and needed to go to the rehabilitation center for the wound care and to restore some of the function that was lost during the stroke. It was challenging for the patient to move from an independent setting, being at home and doing so good and driving and taking care of the dog and attending family gatherings, now being in a rehabilitation center with challenges with mobility and pain and wound care. So when I got to meet the patient, I work really hard with the patient, but also with the adult children on how we can start planning ahead of what's the next living environment, how we can best help the patient go back home, working with the social worker at the skilled nursing facility, working with the primary care provider of the patient, and working with one of our nurse practitioner and the physical therapist and the wound specialist. So a truly interdisciplinary team taking care of the patient. The patient did really well, progressed with therapy, regained a lot of the function. The wound got much better. And we were able to dismiss the patient back home. We were able to set up some additional home physical therapy. And we actually enrolled the patient in one of our homebound programs. Because of some residual mobility limitations, it's challenging for the patient to go to the clinic for some appointments or getting blood work. So we are setting up some home visits and home physical therapy and home healthcare services and home wound care. So a lot of supports for the patient to be at home and continue working on regaining function, and for the adult children to feel relieved that there's someone also helping the patient at home.
Yeah.
So that's a success story for me.
Yeah.
Let's see how it goes.
I love that. No, I agree with you, though. Any success story is when someone is able to stay safely at home, out of the hospital. They may end up in a rehab for a short period of time, but are able to go back home, ideally better than their baseline. And then having the realization that, gosh, this is a wake-up call. And perhaps there's things that I need to be doing or changing or adding into my cares now to prevent this recurring pattern, right? We see that all the time and see that as a success story, but with the help of that village that needs to come together between family and social services and the healthcare providers, it just involves so many layers of people and processes. You mentioned about the homebound program. Can you share a little bit more about that? The one that Mayo offers to improve care transitions. And I know there's other homebound programs around the nation, but what are the key components and the key players there?
Yeah, you say it really well. Like, it takes a village, right?
Yeah.
So Mayo has 3 different homebound programs. One of them is the care transition program that is actually the model for helping those patients that are high risk for going back to the hospital. And we have a wonderful group of nurse practitioners, nurse coordinators, palliative care physicians, geriatricians, ethicists, internal medicine physicians, social workers, pharmacists, that we get together to think about that specific patient and see how we can best help them for a limited amount of time, helping them to stay at home and avoid another hospitalization. The other 2 programs are the primary care house call program and the palliative care homebound program. The palliative care homebound program is for those patients that have conservative goals of care. They would like to avoid further hospitalizations, emergency department visits, and they really have a approach to the medical care of palliation of symptoms, meaning if I were to have a new diagnosis of a malignancy or cancer, I really would like not to have surgery or further treatment. So we help them stay at home, avoid hospitalizations, concentrating our efforts on alleviating symptoms. And whenever the time comes and they are at the end of their life journey and eligible for hospice services, we help them with that transition.
Right.
And the primary care house call program is for those patients with multiple medical problems that may not be ready for that palliative care approach yet, but they still have a lot of difficulties with maybe mobility or cognition or transportation or multiple medications. So we visit them at home as well. And it's amazing. It takes a village. We are a really fun group to work with. We can do blood work at home. We can do x-rays to help the patients stay at home.
Yeah. Try to make it as easy as possible for them. Right?
Exactly.
And what about technologies that are helping with home care nowadays? Are there other advancements that are enabling patients to receive care while staying at home so they don't have to go to the clinic as often?
We can use technologies such as remote monitoring, and that can be a way of checking their vital signs for like their blood pressure and heart rate and oxygen levels and weight. Other ways is those continuous glucose monitoring that can check the blood sugar levels of the patients remotely, and we can see when the numbers are off. And telemedicine, that is a way to reach some of those patients that may be having additional difficulties to visit some of the other specialties that are not providing home visits.
My last question for you, and this is kind of a tradition we have on our podcast here, is we just would love to get to know you more as the expert, as the geriatrician who cares for so many older adults. What does aging forward mean to you? How do you personally like to age well? And what do you hope to be doing in your later years?
I think about aging forward as adaptability.
I love that.
And resilience. I don't know how this is going to look on my coming years. So it's how I will adapt to whatever comes my way.
Mm-hmm.
And how I'm planning on aging. Obviously, staying active is one of the most important things, but connections and meaningful connections with, family members, loved ones, friends, with the community, with maybe religious organizations, so with my colleagues like you. So meaningful connections and staying active. I think that's how I hope to age well.
Mm-hmm. Sometimes it's just the simple things, just being able to be at home and do what I want and being adaptable, nimble with whatever life throws your way. So thank you for that reminder, Dr. Mendoza.
Thank you for inviting me.
That's all for this episode. Hopefully you're feeling a little bit more informed, inspired, and empowered. On the next episode of Aging Forward, caring for your mental health as an older adult and healing from past trauma.
Trauma is not always the big and obvious experience like people think, like accidents or violence. It can be more subtle, like growing up in an environment where your feelings are being dismissed, or that you don't have a voice to express yourself, or you feeling afraid to express yourself. Those experiences often leave a mark, and they shape how you respond.
If you have a topic suggestion for a future episode, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. For more Aging Forward episodes and resources, head to mayoclinic.org/agingforward. And if you found this show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, stay curious and stay active.
This podcast is for informational purposes only and should not be relied upon as medical or legal advice. Always consult with a qualified healthcare provider for any medical questions. The appearance of any guest does not imply an endorsement of them, their employer, or any entity they represent. The views and opinions are those of the speakers and do not necessarily reflect the views of Mayo Clinic. Reference to any product, service, or entity does not constitute an endorsement of or recommendation by Mayo Clinic.